is, last year we had myself and Ian Tyndall were kind of asking each other a few questions. And I think some of the comments were around, we actually need a half day for this sort of thing. Once again, we don't have a half day. We've pretty much got 45 minutes. So what I've done is I've asked Gary Allen from Director of HREC, Australian Health Research Ethics Consultancy Services, one of our sponsors, Hudson Burden, the chair of Townsville Hospital and Health Service Ethics Committee, and Sonia Hancock, the newly inaugurated chair of the Gold Coast Hospital and Health Service Ethics Committee, just to answer some questions around the national statement, changes to the national statement, risk, etc., and some other questions I have lined up for them. So I will orchestrate this, but I will first share my screen so we can orchestrate appropriately. Oops, daisy. Share screen. Okay, I guess that one. Let's see how we go there. Very good. Not working. No, I've got the notes page, so I have to.
Yeah, you need to swap that gun.
Remind me how I do that one, Sarah.
There's a function saying, see display settings?
Can't see that on my.
No, it's on your presentation. Display settings is an arrow at the top. Yep, up, across a little bit, across. Across a little bit more. Can you see that display settings?
I'm just blind as a bat. I can't see it. Oh, look, let's not worry about that. I'll sort that out as we go. I just have to change the screen. Nevertheless, so what I will start with is that, and I don't have any notes, so it doesn't really matter, is that there were some changes to the national statement, largely section 2.1 on risk and section 5 on research governance. So the changes to the risk were that the NHMRC has decided there is what they call the risk continuum, but one of our members decided it wasn't a risk continuum, but was in actual fact just categorization or stratification. It doesn't really do much apart from to say things are low risk and lower risk, and then more than lower risk, based on whether there are harms and burdens and discomfort involved. The greatest thing about what I believe what's happened in the new national statement is that they have suggested that some clinical trials can be lower risk. So my first question to, I guess, Hudson and Sonia are, do you think the changes to the national statement in terms of risk will affect the way you change your view, or change your ethics committee changes its review?
What do you think, Sonia? Do you want to answer first?
Sure thing. Look, like all good things, like all good research projects, it's very context specific. So in terms of clinical trials and lower risk, like if you're doing a standard of care comparator trial where the risk and the safety profile is well established, and it's just a question of, you know, physician's choice A versus physician's choice B, the opportunity for that particular clinical trial to be reviewed under a lower risk review pathway is certainly there. But it's very much a case-by-case basis. The biggest shift that I see is that there is going to be more emphasis on, in particular, applications for considerations under the exemption pathway. So it still might be research, but given the level of risk, like we're talking about, you know, potentially non-identifiable data sets where research groups may be going out to a public event such as a music festival and seeking an anonymous, you know, viewpoint of participants in terms of, you know, health and well-being during the festival, for example. Those sorts of things we'll probably see more and more, and it's about the institution having a bit of a shift in thinking in terms of how it's going to manage and adequately support those types of activities. That's where I see the biggest shift occurring. Hudson, do you want to add anything?
Well, I agree with your points. I further think that we're only going to find out what these changes mean through use when we go to apply them and say, oh, okay, now we've got this wording. How should we think differently than what we have been thinking? As regards clinical trials, as we've already heard in the last couple of presentations, the clinical trial framework is becoming ever more complex. with more danger first in human trials. And we're seeing a lot of that, as Kelvin told you. Kelvin, of course, is on my committee and was a chair of it for several years. So that's an evolution that's in progress. In Townsville, we set up 2 years ago a pathway for low-risk applications that don't have to go to full committee. It's called Acquire. 2 people review an application. It's mainly for clinical audits, things like that. And it's a fast turnaround for researchers. It takes a burden away from the full committee, and it's worked very well. So I'm going to be interested to see how the new statement overlays with what we're already doing. I think it's going to overlay well, but as I say, we're going to have to use it for a while to see what it's like.
Now, Gary, feel free to comment.
So all I was going to throw in is, I think it's important that institutions have a triage process. So the chair and the secretary look at what researchers have suggested about risk level to judge whether or not it's correct. And then actually in the review process for the HREC, then specifically reflect on that. I think it's worthwhile at the end of a 12-month period, looking at the reviews that have occurred in that year, just to reflect on, was what people judging with their risk, was it accurate? Are our guidelines useful in terms of risk? So I'm not talking about re-prosecuting an application. What it's about is reflecting on whether our processes are working properly. Apologies if I'm confused everyone. My day job is at Griffith University in the Office of Research, which is why I've got a Griffith background. So apologies for any confusion.
Thanks, Gary. And I think, as I said, the fact that clinical trials are now recognised as a potential for lower risk, I think, is really valuable because, and probably I'll touch on this in the coordinator session tomorrow, if we consider they're all the same level of risk, then I think we really disenfranchise many participants. And many trials, in actual fact, are probably no more than clinical improvement anyway, or an N of 1 trial could be considered clinical improvement. So, potentially we miscategorize things, but this added flexibility, I think, is very helpful. Apart from that, Gary, I don't disagree with your triage comment, but I think we would all hope that ethics committees wouldn't necessarily leave the decision about risk levels to researchers anyway, although it's a guide, but would make that decision themselves. So I think flexibility.
We have to do that. We have to take that out ourselves.
Yeah. Flexibility in reviews is important. Okay, so let's move on from risk. Research governance aspects in the national statement that have changed. Exemptions are granted by the institution. Personal information gained without consent cannot be exempted. So I think that's actually been emphasised. In 5.1.22, of course, the use of non-identifiable pre-existing data sets was allowed to be exempt from research, but I think that clarification is helpful. We've talked today about the memberships of committees. The pastoral carer is now no longer a minister of religion or an Aboriginal elder. They are examples thereof, but in actual fact, it's about people that provide a wide community benefit. And that is a very sensible addition, because I think there are many people that can provide this pastoral care role, and it shouldn't just be limited in that religious sense or Aboriginal elder sense. And of course, the lawyer, you don't actually have to be a practicing lawyer. So those of us who are not practicing lawyers can still fulfill the lawyer membership on an ethics committee.
And I don't know about anybody else, but we're finding that slot to be the hardest to fill and to maintain.
I think there was, if it was ever thus, Hudson, trying to get professionals to volunteer the time is a difficult ask. We have also talked about gender diversity today, and that is the case in the national statement. Okay, some questions for discussion. We've just dealt with number 1. Now, Sonia, I'm just going to throw to you, because as a new HREC chairperson, and bearing in mind the audience, what do you think are the challenges that you face as an HREC chairperson, noting you haven't been in the gig for too long?
Yeah, absolutely. So I joined the Gold Coast HREC at the end of September, and my very first day on the job was as an observer of the actual sitting of the HREC. Now, despite being in and around supporting HRECs across Metro South and the MARTA, being the chair is a very different function. But more importantly, it's about very quickly. So probably two challenges that I'd hone in on is very quickly and succinctly being able to build rapport and establishing relationship with members. And in terms of how to overcome that, one of the things that we've certainly started to implement at the Gold Coast HREC is empowering the members. So giving each and every member an opportunity to bring something to the table. So in terms of our education section on the agenda, I've invited each of the members to present 5 to 10 minutes on their subject matter expertise, on what they bring to the table. This actually, it gives them, a significant sense of contribution, but also allows to share the background of their knowledge base and, to sort of demonstrate where they come from. It also, it really enables that peer-to-peer education component, as well as satisfying some of the educational requirements around the national statement. But the other thing.
Sorry, Sonia, you're on mute. That was my fault.
Okay, yeah, I saw that. I'm like, okay, is it time to be quiet? So the other big issue is recognizing what the key issues facing the HREC are. So every, committee will have a suite of research application types based on the area that they serve. And, to be fair, one of the big catalysts for change is the introduction of the National Clinical Trials Governance Framework. And knowing the compliance regulatory functions around what and how research should be conducted, and combining that with what we see presented before us, kind of does offer an opportunity to not just be the yes, you can do your study, or no, you can't do your study, but actually have a seat at the table to discuss how research can be conducted appropriately with the appropriate considerations put into place. So, the participant information and consent forms, it's a stock standard issue across every single agenda. So being able to, put in measures and contribute to organisational systems and processes is certainly going to be a key to avoiding wasting valuable HREC members' time in the future, in terms of if a PICF isn't pitched at the right level, the researchers have an opportunity to actually fix that before the application is reviewed by the members. So they're just probably the two biggest things that I've seen in my very short tenure of 3 months.
And Sonia, just on that last point, what are your thoughts about, ensuring that information sheets actually come to you having been to the, through the co-design or as we talked about, participatory design process?
Yeah, absolutely. You want to see some, evidence of consumer engagement, whether that be via a plan or, some sort of supporting documentation as part of the application. One thing that, we are looking at potentially doing is running the PICFs through a readability program. It's, free, it's available on the web, just to make sure that it's pitched at the right level. And you really want to see evidence of that that consumer engagement right at the outset. And I think, to be perfectly fair to the membership, if it's not there, it really either needs to be justified as to why it isn't, or, as I said before, researchers need to be given the opportunity to fix that before they present the application for review.
Very good. Might just move through the questions, if that's all right. Gary, how do we... You raised the issue of ethics creep. Would you care to explain that and perhaps provide a solution for it? How do we stop ethics creep?
Yes, I think there is a tendency nationally, if not internationally, for institutions to send any issue that they might be concerned about to an ethics committee, whether that's ethics or governance. And so, yellow and blue cards are probably a good example in terms of, who's actually responsible for checking a researcher has got a card in place, or the NDIS card, I guess. Now we're talking about the NDIS. So, I think part of that is chairs and committees need to reflect on, is this something the national statement says a HREC should be looking at? If it's not, really, what is the basis for us having that discussion? So I think committees don't need to be aggressive, but they do need to protect in terms of what are we supposed to be spending our time doing. There's enough work for HRECs to do already without taking on other tasks. So I think it's something that we really need to safeguard against. If you'll forgive me just for a second, Gordon, just looping back to the discussion before, one of the things that RX have been doing quite successfully is doing what we call fishbowl exercises, where half the committee reviews an application while the other half of the committee is observing them. After the end of that review, the other half gives feedback to the half that reviewed, and then they swap roles so the the other half is observing and giving feedback. We found it's a very useful way to actually, for the committee to talk about the dynamics of review and what the committee's doing with the review. So, that's something that we've done around the country a few times. So, yeah.
Thanks,
anyway.
Gary. And look, on the point of ethics creep, clearly there are issues which are governance, and clearly there are issues which are HREC, as you say, which are and our remit is given to us by the national statement. And a good example could sometimes be the difference between, excuse me, a human research ethics committee and clinical governance at a hospital. How people act at a hospital is the responsibility of clinical governance. It's not the responsibility of the ethics committee. So I think these things being clear about that. But the difficulty there can be around legal issues and the responsibility of ethics committees in terms of, and I think some of these questions might highlight it, their responsibility around privacy or human rights.
Yeah, so privacy is a really good example. So the Privacy Act does actually refer to the ethics process. So there it's quite obviously appropriate. But I think what chairs and committees need to be alert for is how it might change your dynamic for your interface with researchers. So if you are straying into other areas, I think that unhelpfully changes your relationship with those researchers. So hopefully ethics review is seen, and what it's doing is about giving feedback to researchers to facilitate their research, is not to police their research. So I think ethics committees need to be quite strong in terms of, is this something that actually is our job?
Yes, and before Hudson, I'll turn to you. I'll just say, Gary, that I'm a big fan of the essential versus the nice to haves.
Yeah.
And making sure we focus on our role, and that an ethics committee member can, if they wish to ask a question, they can relate it back to the particular section of the national statement.
Yeah.
Otherwise, largely it's out of scope.
Yeah,
Hudson,
exactly.
Thoughts on that one, Hudson?
Well, yes, as far as ethics creep goes, psychedelic assisted therapy is a good example of that. The only one I've encountered in the years I've been involved, this is a task that really is more fitting to a clinical ethics committee, but it's been specifically by the TGA directed to us, and takes us out of our comfort level and takes us possibly, arguably, out of our competency level. I won't say more about that now, because of course I'm going to be talking about that later. And Ian,
yes, you will, as will probably two other people, in fact, but I look forward to that discussion as well. Okay, let's go to number 5. Oh, sorry, no, let's go to resolving differences in approval, Hudson, and how to resolve an issue where an ethics committee approves a study, yet another one does not believe it should be approved.
There is no pathway for resolution now, and I don't see one on the horizon. To truncate the story, I've been involved in a battle with a major player. As far as power differential, it's definitely David versus Goliath, except in the story, David won, and I'm losing. But and I, of course, can't share much about the project, except that was involved invasive research on First Nations people, and was essentially a data mine, did not conform to the requirements of the national statement for consent or for proper treatment of people in the study. And our committee found it the worst application we'd ever seen. We denied it. Other committees have approved it, and my information is that the study is going on. It came to us with an approval from a private ethics committee, which had no conditions, just, yes, fine, go ahead. We contacted the NHMRC, who basically shrugged their shoulders. I contacted the federal minister for health, and have also tried to work at the state level through First Nations groups as well as organizations, and have gotten absolutely nowhere. So we're left with the potential of either now instituting a complaint for inappropriate research, or waiting until the study gets published and then pouncing on the journal and saying this study should not be published. It didn't meet ethical requirements. But of course, they will then, the authors, be able to show the ethics approvals they did get. So I'm at a loss. I do not see a pathway. I see this as a big problem. And we've had other applications where we've said no and heard nothing. And I'm fairly certain these people have gone elsewhere for approvals. And we don't even know about that. At least this one big application we know, because they told us, well, we're just going elsewhere and getting approvals, and we're going to do it where we get approvals.
And I think, Sonia, before I turn to you, I think, Hudson, it was discussed yesterday potentially that the issue around allowing ethics committees to interact with each other, it's not something that's traditionally done, but there should not be any reason for that not to occur.
Well, I contacted the ethics committees that we knew of that had approved this, and after an initial phone call where I was told we'll get back to you, just dead silence, no further communication. So nobody is willing to talk, committee to committee. In my experience on this issue, I don't want to generalize it over much. Okay, Gary.
I was just going to observe in terms of applicants that lodge applications and then goes silent after they get feedback from the committee. I'm a big fan of escalating terseness in that interaction with researchers. So as time passes, us getting stronger in terms of our outreach, and if they arrive at a point where they are, that multiple days have passed, being quite not punitive, but certainly being a lot more demanding. I think having on policy that if someone's applied for a clearance and then not continued, and it turns out they have gone ahead and done the research, that is a breach of the national statement. So
it's also a breach of the code of conduct for research.
Yeah, exactly.
Lots of other things.
Yeah, so I mean, in terms of breach of the code, you might even be talking as far as research misconduct. But
yes, we haven't gone down that path yet, but we're looking at it.
Yes, I mean, I think just reflecting in terms of your policies, if it gives you a policy basis so that it's not just a decision the committee has made on its own, it's as per the institutional policy. But I think there needs to be consequences if people do that.
I think, Gary, it sort of goes back to the fact that while ethics committees approve research, the monitoring thereof and the oversight, once that occurs, is potentially not sufficient. And I'm sure most institutions would agree, or I'm not sure whether they agree, but most institutions do not seem to have the resources to monitor research as such. Take your point. I guess if someone hasn't, if you've provided comments back and they've done nothing about it, then the research isn't approved. Then it is no longer within the realms of the HREC, but within the realms of institutional governance. So I wouldn't totally agree with the HREC being involved there. Sonia, your thoughts there?
Look, I think it's important to recognise that, like as you just said, the institutional governance, not framework, but certainly the ethos. The ethics committee primary responsibility is to focus and hone in on the ethical and scientific validity of a study in terms of integrity and merit, respect, beneficence, and justice. Certainly, where there are concerns and where the request for further information has gone back to the researchers and, a request for justification in terms of their approach, and it's silent, there is, under the Code for the Responsible Conduct of Research, there is an imperative for researchers to disclose any other peer review or comments that they may have received from another HREC or other ethical review body as part of a new submission. Now, I'm not, as much as I like to live in utopia, I'm not that naive to say that automatically gets done. But the responsibility does sit with the researchers. And in terms of their own reputation and institutional considerations around legal, financial, and all those other risks. This is where research governance as a whole, I'm not talking about the site-specific assessment perspective, but research governance as a whole has to be put into place. Yeah.
Yes, Gary, did you want to make a comment on that? Oh no, you're sorry, I thought your hand was up.
You're muted.
That's fine. I did have a comment, but it's totally escaped my mind. Not to worry. Let's move on to number 5. Does an institution as an operator of a large business conducting research have a potential conflict of interest in relation to a research proposal? And what's the role of the HREC in relation to this? So we sort of talked about this last year. Should institutions conducting a clinical trial have their own HREC approve it? Or should there be a mechanism for an external approval? Hudson, have you care to comment on this?
I first got to ask you, how are you defining institution here? Are you saying a hospital that's got research going on in-house applying to its own HREC, or are you talking about something like
university, medical research institute, or hospital? Let's just say a smaller institute, let's say. Should you be able to approve your own clinical trials where you may stand to gain from them?
I find it a hard question to address. I'm trying to use the mental model if someone in our hospital applied to us to do research, which of course happens all the time. We are part of the hospital, but we also operate independently. The hospital cannot tell the HREC how to rule on an application, nor can the hospital penalize an HREC for acting on an application. Or if they tried to do so, there should be legal remedies, although that could get messy. And because the HREC is outside the framework of things, I would say that the potential for conflict of interest is minimal. We could go back to the New Zealand tragic experiment and argue that, because that's been argued all over the place. But the initial argument for what was bad about it was the close connection between the ethics committee and the researcher. That does potentially present a problem. And if I was very close to a certain researcher, I think I would, for my own personal integrity, stand aside and say that somebody else, one of my deputy chairs, or maybe another ethics committee should oversee what we're doing to remove the perception. Because there would always be a perception, or the potential for a perception, of conflict of interest. But the reality is not something I stay up at night worrying about.
And of course, you come from a hospital health service, which is a larger institution. Similarly, Sonia, you come from a larger institution. There are smaller ones, of course, and if a small institute is approving its own studies, what oversight is it subject to? Lynn has suggested, a couple of suggestions in the chat. Ensure you appoint an independent HREC chair. Well, that's fair enough. Sometimes it's not the actual conflict of interest; it's a perception of conflict of interest one has to deal with. So, people's perception is their perception, and we can't disagree with that. But I think, Lynn, you've pointed out that attach evidence of the outcome of scientific or academic review process. And I guess another way is to have an independent entity that might, independent from the institution, that might review aspects of it, such as the, scientific merit, for example. Sonia, please comment.
Yeah. So, there's the biggest thing is about transparency and having processes, made available in terms of how a HREC actually looks at applications. And between, risk mitigation strategies around conflict of interest, if there is anyone on the HREC membership who is, working with the research team, then that gets declared and managed appropriately. But also the fact that there is a requirement to have members of the committee who are actually external to the institution, that should provide a level of assurance of that independent nature. And again, given the fact that, the committee looks at the ethical and scientific validity And then there's another arm of the organisation that looks at the research authorisation in terms of that, there's governance arrangements. I certainly think there are sufficient protections in place that assure that independence review.
Thanks, Sonia. Before Gary, I go to you, I will just say that in actual fact, it's the committee that makes the decision and not the chairs. So having an independent chair is not a guarantee of independence by any means. However, the committee makes the decision, and so obviously there is a pathway for people not to agree for that decision to be made. And I think that's quite a good check and balance, that one person does not hold the power. So any chairperson that makes decisions in the absence of unanimity or even consensus is acting ultra vires, I would suggest. Gary, over to you.
So just a couple of quick thoughts. I think even for reasonably large research institutions, the budgetary landscape that we're all in, a big commercially sponsored clinical trial is a big deal for an institution. I think that does equate to some degree of interest from leadership in terms of the handling of that work. So that can put pressure on committees. Yeah, as you say, I don't think on its own an independent chair is going to change that. The reality is that HRECs operate with the support of an institution in terms of staffing and resourcing. So, there is interaction there, but institutional conflicts of interest are real. I think committees being aware of that is incredibly important. The last thing I was going to observe, I think a good manifestation of that issue is the question of have the results of this clinical trial been widely distributed, even if it's not quite what the commercial sponsor was hoped the results were going to be. I think that is part of the role of the ethics review process that reporting occurs.
Now, it's 12:43. We've really got 2 minutes, so I'm just going to ask one more question. I'd love to ask about 20 more, but there you are. Why is there no effective scrutiny of the operation of HRECs, Sonia?
Look, I think that's historical in nature rather than intent. I strongly believe that, we should absolutely, if we're expecting researchers to be accountable and to be, operating in accordance with the Code of Responsible Conduct of Research and with the national statement, similarly, HRECs should be too. There are a lot of reasons, primarily, and I'd be naive not to say financial, in terms of how that's managed. And there's, well, who does provide that scrutiny, and where does that accountability loop end? I think we had a presentation yesterday that just talked about this very issue. So, historical is in the past, and I think now is the time to consider, particularly with the framework and also the good work that Dr. Conor Brophy is going to be talking about later in terms of accreditation for HRECs. Now is the time to make the accounter, if you like, accountable as well, so that we're all, providing that closed loop responsibility to ensure that we're actually delivering a good service.
So Hudson or Gary, any thoughts on the scrutiny of HRECs?
Well, I'd say the answer to the question is that there hasn't yet been a scandal big enough for people to stand back and say, oh, gee, if only we had more scrutiny, that might not have happened. The saving grace of that is maybe we're operating at a competent and professional enough level so that there's no need for it. Certainly, it's a role the NHMRC could have played, and there is certification now of HRECs, but it's fairly pro forma, fairly cursory. And other than the historical reasons, those are my answers.
Thank you so much. Gary, any thoughts on that before I close the session?
Yeah, so I think what we're seeing is an increasing awareness of journos and polys in terms of what we do and how it's supposed to operate. So, picking up on Hudson's point, I think if there is a big scandal, it's more likely there will be that kind of reaction. I think Australia desperately needs a national independent body that can provide that sort of quality standards. I think that there are ways to pick the qualities of quality review in terms of committees. So, I mean, I think we need some more standards because not all committees are made equal.
Very good. I'm a big fan of the peer review of HREC, so we'll get to that in the next year or so. And just to point out, Rob Lobley has pointed out for the Sydney Local Health District HREC, our hospital has to go through an accreditation process every 5 years. That includes scrutiny of HREC processes and operations. Now, Gary, because this is really the RX session, happy to give you a minute or so to talk about RX, and then we're going to move swiftly to the next speaker. So can I just thank Hudson and Sonia for your input? I'm sorry it's so short. An hour is not long enough for all these questions, but you can see the questions on there. We will organise, I think, a longer session subsequently. But Gary, over to you to talk about RX if you choose.
Yeah, so we're delighted to be involved again this year. So this is an incredibly important activity that's been going on. So congratulations again to Gordon, Sarah and the team in terms of putting the event on. So RX, we have been conducting professional development as well as reviews of institutions virtually in terms of processes and giving feedback in terms of the institution and the resources you have for researchers. We've worked across Australia the last couple of years in New Zealand, the UK, and just recently into Kazakhstan and Asia. So we are a very, very small international consultancy firm, but we'd be delighted to hear from any participants if you want to discuss how we might work with you.
Thanks, Gary. Good plug there, but always good to have sponsors support this event. Okay, we're going to move on right away.